In managing type 2 diabetes, the American Association of Clinical Endocrinology emphasizes a glucose-centric approach, a structured yet flexible pathway that places blood glucose optimization at the heart of therapy. This algorithm guides clinicians through practical, evidence-based decisions, starting with lifestyle and metformin, then tailoring pharmacologic choices to each patient's unique profile. By integrating comorbidities, hypoglycemia risk, weight considerations, and cost factors, it transforms complex data into clear, actionable care. In the following sections, we'll explore how this framework adapts across 4 key scenarios, from severe hyperglycemia to high hypoglycemia risk, ensuring every patient receives individualized, safe, and effective treatment.
Jack is a 56-year-old real estate agent, known for long working hours, irregular meals, and high stress levels. He was diagnosed with type 2 diabetes 8 years ago. His initial treatment was metformin, later escalated to glycoside MR 90 mg daily due to rising glucose levels. Jack's family history is positive for diabetes. His mother developed type 2 diabetes in her late 50s. His BMI is 31 kg per square meter, placing him in the obesity class 1 range. Despite being on dual therapy, Jack's adherence has been inconsistent due to his demanding job and frequent travel between properties. Jack presents today for a scheduled follow-up after experiencing worsening symptoms over the past 3 months. He reports polyuria, waking up 3 to 4 times at night, polydipsia, drinking water constantly, fatigue, especially midday, blurred vision, difficulty reading contracts, unintentional weight loss, 4 kilos over 2 months, dry mouth, occasional nausea, difficulty concentrating. His labs today show A1C, 11.4% random glucose, 318 mg per deciliter, fasting. Glucose, 292 mg per deciliter. Normal renal function, no ketones detected. These findings place Jack clearly in the severe hyperglycemia category.
Jack, your symptoms of thirst, frequent urination, fatigue, and weight loss tell me your blood sugar has been very high for a long time. Your A1C is 11.4%. which means your pancreas is struggling to produce enough insulin.
I thought it was just stress. But I've been losing weight without trying.
That weight loss is actually a sign that your body is breaking down fat and muscle because it can't use glucose properly. This tells me your diabetes has shifted from mainly insulin resistance to insulin deficiency.
So what does that mean for treatment?
It means we need to start basal insulin now to stop the catabolic state and bring your glucose down safely. We'll also add a GLP-1 receptor agonist to help with meals and support weight control. I want to be honest with you. At this stage, insulin is likely to be part of your long-term treatment. Your pancreas has been working hard for years and is producing less insulin now. In the future, you may even need a multiple daily injection regimen if your post-meal sugars remain high.
That sounds serious.
It is, but we're catching it now. Starting insulin will protect your eyes, kidneys, and nerves. And we'll take it step by step. You won't be alone in this.
Jack's unintentional weight loss indicates catabolic stress and emerging insulin deficiency, not just insulin resistance. His A1C of 11.4% and glucose more than 300 mg deciliter confirms severe hyperglycemia requiring immediate insulin therapy. Basal insulin is the correct first step, but Jack should be prepared for possible escalation to MDI insulin if postprandial control remains inadequate. This approach aligns with the AACE algorithm and reflects the natural progression of long-standing type 2 diabetes. Rose is a 70-year-old retired English language teacher. She has lived with type 2 diabetes for 20 years, managing her condition with oral medications for most of that time. Recently, Rose developed chronic kidney disease, which has changed her overall health status and increased her vulnerability to complications. She lives alone, and because of this, her meal pattern is irregular, sometimes skipping meals, sometimes eating late, and often having small snacks instead of full meals. Over the past months, Rose has experienced episodes of dizziness, shakiness, and confusion, especially on days when she eats very little. These symptoms raise concern for hypoglycemia, particularly in elderly patients with CKD. Rose's age, kidney disease, and irregular meals place her in the high hypoglycemia risk category of the AACE algorithm.
Good afternoon, Rose. I reviewed your recent labs and your kidney function has declined a bit. This affects how your diabetes medications behave in your body.
I've been feeling shaky sometimes, especially when I forget to eat.
That's exactly what I want to talk about. Because of your age, your kidney disease, and your irregular meals, you are at high risk of hypoglycemia. Some diabetes medications can cause your sugar to drop unpredictably.
I didn't know that. What should we do? Which medicines are safe for me?
I'll explain each one clearly so you know exactly how they work. One option is a sodium glucose transporter 2 inhibitor, or SGLT2 inhibitor. This medication works by preventing the sugar filtered by your kidneys from returning to your blood. Instead, your body gets rid of the extra sugar through urine. It doesn't cause hypoglycemia because it doesn't force your pancreas to release insulin.
That sounds safe.
Another option is a glucagon-like peptide-1 receptor agonist, or GLP-1RA. This medicine helps your body release insulin only when your sugar is high, slows digestion, and reduces appetite. Because it works only when needed, it does not cause low sugar. We can also use a dipeptidyl peptidase 4 inhibitor, or DPP4 inhibitor. This medication keeps your natural insulin-regulating hormones active longer, helping your sugar stay stable throughout the day. It is very gentle and does not cause hypoglycemia. Metformin reduces the liver's sugar production and improves insulin sensitivity. It does not cause hypoglycemia, but we must check your kidney function regularly to make sure it's still safe for you.
That sounds safe.
Rose, because you live alone and your meals are irregular, I strongly recommend using a continuous glucose monitoring sensor. It will alert you if your sugar is dropping. If you prefer, you can also do frequent fingerstick glucose checks, especially before meals and at bedtime.
That would make me feel safer.
I also want you to know exactly what to do if your sugar drops. If your sugar drops, you may feel shakiness, sweating, dizziness, confusion, fast heartbeat.
What should I do in this situation?
Take 15 grams of fast sugar, 3 teaspoons of sugar, or half a cup of juice or glucose tablets. Then wait 15 minutes and recheck your sugar. If still low, repeat the same step. After you recover, eat a small snack to keep your sugar stable. Always keep sugar tablets or juice near you, in your bag, beside your bed, and in the kitchen.
I will. Thank you for explaining everything.
Rose is in the high hypoglycemia risk category because she is elderly, has CKD, lives alone, and has irregular meals. The AACE algorithm recommends avoiding medications that cause unpredictable glucose drops, such as sulfonylureas and glinides. The preferred medications, SGLT2 inhibitors, GLP-1RA, DPP4 inhibitors, and metformin, all have minimal hypoglycemia risk and are safe for patients with inconsistent meal patterns. Continuous glucose monitoring or frequent self-monitoring is strongly recommended for safety. Education on hypoglycemia recognition and treatment is essential for patients living alone. This approach prioritizes safety, stability, and simplicity, ensuring Rose receives treatment that fits her lifestyle and protects her from dangerous lows. Bill is a 45-year-old man who works long hours as an accountant. Over the past decade, his weight has steadily increased, and today his BMI is 41 kilograms square meter, placing him in the Class 3 obesity category. He was diagnosed with type 2 diabetes 3 years ago, initially managed with lifestyle advice and metformin. As his glucose levels worsened, glycoside MR 120 mg daily was added. Despite treatment, Bill's diabetes remains uncontrolled. His most recent HbA1c is 9.2%, and he reports feeling tired, gaining more weight, and struggling with cravings and late-night snacking. He has no known complications yet, but his metabolic risk is high. Today, Bill visits his endocrinologist seeking better control and asking whether stronger medications might help him lose weight.
Bill, I've reviewed your labs. Your HbA1c is 9.2%, which tells me your diabetes is not well controlled. And with your BMI at 41, your weight is playing a major role in your blood sugar levels.
I know, doctor. I've tried diets, but I always regain the weight. And I'm worried my medications might be making me hungrier.
That's a very important point. Glycoside can cause weight gain and hypoglycemia. For someone with obesity and high A1C, we should shift to medications that help with weight loss, not worsen it.
So there are diabetes medications that help with weight too?
Yes. According to the AACE algorithm, patients with obesity and uncontrolled diabetes benefit from GLP-1 receptor agonists, or SGLT2 inhibitors. These medications lower blood sugar, reduce appetite, and support weight loss.
That sounds promising. Will I stop glycoside?
Yes, we'll discontinue glycoside. It increases the risk of hypoglycemia and weight gain. We'll keep metformin and add a GLP-1 receptor agonist, which is one of the most effective options for both diabetes control and weight reduction.
I'm ready to try it. I want to get healthier.
Great. We'll start gradually, monitor your glucose, and support you with nutrition counseling. This approach targets both your diabetes and your weight together.
Bill has obesity as his BMI is 41. He has a poor glycemic control. His HbA1c at 9.2% despite metformin and glycoside. Sulfonylureas like glycoside promote weight gain and hypoglycemia, making them unsuitable for obese patients. The AACE algorithm recommends GLP-1 receptor agonists and SGLT2 inhibitors as preferred agents for overweight and obese individuals with type 2 diabetes because they promote weight loss, improve glycemic control, reduce cardiometabolic risk, have low hypoglycemia risk, improve satiety, and reduce caloric intake. Therefore, discontinuing glycoside and initiating a GLP-1RA with metformin continued is the optimal strategy for Bill.
Susie, I've reviewed your recent tests. Your A1C is 8.8%, which means your blood sugar is not within the target range we aim for in diabetes treatment. I know you've been trying, so let's talk about what's making this difficult.
Doctor, I really try my best, but I have a very small budget. I'm raising 4 children alone, and sometimes I barely manage to buy food. The last medicine you gave me, the SGLT2 inhibitor, dapagliflozin, it was too expensive. I bought it only once, and I couldn't afford it again.
I understand, Susie, and thank you for telling me. Your situation is very real, and cost should never stop you from getting proper treatment. The good news is that there are effective medications that are much more affordable.
Really? I didn't know there were cheaper options.
Yes. Let me explain them clearly so you know exactly what we can use. We can start with metformin. It's inexpensive, safe, and works very well for most people. If we need more glucose control, we can add one of these low-cost medications, thiazolidinediones, TZDs. Very affordable, but we monitor for weight gain or swelling. Sulfonylurea is also low cost, but they can cause low sugar, so we use them carefully. Glinides, flexible dosing and inexpensive. Alpha-glucosidase inhibitors, AGI, low cost and help with post-meal sugars. All of these are effective, and most importantly, they are within your budget.
That makes me feel better. I just want something I can actually keep buying.
And you will. But remember, medications alone won't get us to the target. To get the maximum benefit, you need to follow a healthy diet and do 150 minutes of physical activity per week. Even walking counts. If we combine affordable medication with lifestyle changes, we can bring your A1C down to the goal.
I'll do my best, doctor. Thank you for understanding.
Susie represents the final pathway of the AACE glucose-centric algorithm. Patients with limited access and a strong need for low-cost therapy. For individuals who cannot afford expensive medications, AACE recommends using effective, low-cost agents such as metformin, TZDs, sulfonylureas, glinides, and AGIs. When combined with healthy lifestyle habits and adherence to the medication regimen, these therapies can achieve good glycemic control and help patients reach their treatment targets. The goal is not only medical effectiveness, it is sustainable care that fits the patient's real life.